Are
You're
you
good.
seeing my screen?
Yes, you're good.
We're good. Okay. So my screen's over here, my camera's over here. I'm going to try and keep my eyes over here so I'm talking to you, even though all I see is mostly just black boxes, but that's okay. As Frances mentioned, my name is Anna Riley, and I am a program lead on the Population and Indigenous Health team at CIHI. For those of you who tuned in to the previous presentation, I do work at the same organization as Janine, but I'm just in a different branch. So today I'm here to talk to you about CIHI's race-based and Indigenous identity standards. I will describe the value of this data and some important considerations related to the collection and use of this type of information. And I will share some insights regarding the work that CIHI is doing on this particular topic. But before I get into it, I will let you know that I'm joining you today from Calgary, Alberta. Calgary is located on the traditional territories of the peoples of the Treaty 7 region in southern Alberta, which includes the Blackfoot, the Stoney Nakoda, and the Tsuut'ina First Nations. Calgary is also homeland to the historic Northwest Métis and to the Métis Nation of Alberta Region 3. I'm acknowledging the land today to reflect my personal and professional commitment to take action to support Indigenous communities and to practice respect and humility in the work that I do. I'm particularly motivated by the Truth and Reconciliation Commission's call to action number 19, which calls on the federal government in consultation and collaboration with Indigenous peoples to establish measurable goals to identify and close the gaps in health outcomes between Indigenous and non-Indigenous communities, and to publish annual progress reports and assess long-term trends. I think this is an area where CIHI can play an important role in collaboration with Indigenous partners across the country. So as Janine mentioned in her presentation before this one, CIHI's role in the health system is really to provide comparable data and information to support healthcare improvement, health system performance, and population health. We have a lot of data and indicator standards to facilitate comparability, whether it be within provinces and territories or across provinces and territories. We use a collaborative indicator development process for developing indicators of health system accountability and performance. But at the same time, I will tell you that we do not have a lot of indicators related to cultural safety and systemic racism. There's very little consistent reporting in Canada on this topic that would be able to shed some light on how we can hold health systems accountable to be able to drive change. And so why might we prioritize equity-related variables? Why might we prioritize the measurement of some of these social determinants of health? I mean, inequities in society are not new, but I think the past 2+ years of the COVID-19 pandemic have really shed some light on the inequities in health and healthcare that exist in Canadian society, and we've seen these exposed like never before. 2020 really brought about a social dialogue about inequity that has allowed us to align forces to enable action. You may recall the murder of George Floyd and the Black Lives Global movement, which has really allowed issues of racism into mainstream dialogue. There was also the murder of Joyce Echaquan, which led to an inquiry into Indigenous racism in BC with a call to action that actually includes CIHI. We also learned through our strategic planning process equity is a key issue for all of their stakeholders across the country. And we know that issues of equity run through other health system issues, including virtual care, long-term care, and mental health. And ideally, we can measure these sociodemographic variables in a consistent way across these different healthcare domains so that we can shed light on some of the inequities and expose inequities in care to essentially find ways to improve the care experience for the different population groups. We've also seen too that this IDEA approach, so the approach that includes inclusion, diversity, equity, and accessibility, is being built into many partnering organizations, including the Health Data Research Network, the Canadian Institutes for Health Research, and different ministries of health. So equity is at the forefront of people's planning and actions, and people are really looking for guidance and direction on how we can bring equity measurement into healthcare. Specifically related to racism in health systems, we've seen a lot of conversations and discussions related to Indigenous specific racism in healthcare. So like I mentioned in the previous slide, there was protests for the experience and death of Joyce Echequan in September of 2020. Then there's this photo of Dr. Janet Smiley. The quote underneath says, "People are dying unnecessarily because of racial bias in Canada's healthcare system." There was the In Plain Sight report that was released in BC, which really called the anti-Indigenous racism into, brought it into more of this mainstream dialogue. And we see that there's different legislations across provinces and territories that's being introduced in order to bring anti-racism initiatives to the forefront. So there's a lot of conversation, there's a lot of discussion about how we might do this. And so that kind of gives you a little bit of the contextual factor for why CIHI has prioritized and worked on the race-based and Indigenous identity standards. So before we get into it, I'll just do a little bit of the definitions of terms. So sameness is not equivalent to fairness. This really is the important distinction between equality and equity. So inequality is a focus on the mere presence of a difference between two or more people or groups on a measure of health. This may or may not be fair. So you can see in the image at the top of the screen, everybody has been provided with the same size bicycle. So that's fair in the sense that they've all been equally given the same resource. But if we think about equity, equity or inequity is an unfair or unjust difference in health. It is systemic, socially produced, and it is avoidable or changeable by policy or practice. But it really has that value judgment associated with it. So we see in the bottom image that all of these individuals have been provided with a bicycle that meets their needs so that they can all actually use that bicycle to get from point A to point B. And so the objective of health equity and how it relates to healthcare is not to ensure that everyone gets the same thing, but rather to ensure that those who need care get the care that they need. And it should be proportional to that need. So as it relates to measurement, we actually measure health inequalities or disparities, but reducing those health inequalities brings us closer to achieving health equity. Janine highlighted a little bit of these different variables in her previous talk. So when we're measuring equity through sociodemographic variables, we have really two primary options. Essentially, they're both data about the person. However, when we talk about record level sociodemographic data, we're talking about actually collecting this type of information about the individual in a particular care setting. So some of these record level sociodemographic variables can include sex and gender, race, ethnicity, Indigenous identity, sexual orientation, religious affiliation, and education, to name a few. These data, when they're embedded in administrative health databases, can really tell us more about the person who is receiving healthcare services, but also can help to guide them to additional resources that may be used to enhance the care that they receive. In the absence of record level sociodemographic variables, we can also look to some of these area-based measures of inequity. So these can include things like race, ethnicity, Indigenous identity, socioeconomic status, education, urban versus rural and remote. And Janine highlighted this in her presentation in the sense that oftentimes we link an individual's administrative record to these area level measures using their postal code. So the postal code allows us to link individual records to some of Statistics Canada data, such as that's collected via the census. And that helps us to describe and understand patterns in some of these variables in the area in which a person lives. For example, postal codes can be classified as urban versus rural and remote, and this can shed some light on access to care for people who live in those areas. You can see at the bottom, there are some pros and cons for both. These pros and cons, they'll become more obvious as we talk about specifically about race-based and Indigenous identity data, but I mean, ultimately, it's making the right decisions about how you're going to ensure that high quality data is collected, if in fact you're going to collect sociodemographic data at the individual level versus in some cases, maybe linking to an area-based measure might be sufficient. There's also pros and cons related to how that data can be used and how accessible it is. So, you know, for example, we saw some different sociodemographic variables included in COVID-19 case report forms across provinces and territories because needed almost real-time access to that sociodemographic data so that they could tailor their COVID-19 response. And so that would certainly be one example of the pros for collecting this data in an administrative data set. So why do we measure health inequalities? Why is health inequalities measurement important? Unless they're specifically measured, inequalities in health and healthcare can go unnoticed by health systems, even as they strive to improve care and health outcomes. So what have we been doing to understand how we can prioritize and different sociodemographic measures? What we did back in March of 2016, acting as a convener, we brought together ministries of health, quality councils, health regions, academics, to really understand what might be some priority areas where we could think about developing standard definitions for equity stratifiers. So in that activity, participants shared their perspectives on data priority needs, to facilitate the measurement of health inequities and health inequalities in healthcare. That first report, which is in the upper left-hand side of your screen, provides an overview of the stakeholder dialogue that was used for this prioritization activity. And we used a modified Delphi process for that particular work. The report describes over 20 commonly used stratifiers like age, sex, income, sexual orientation, and immigration. And it covers some best practices, methodological considerations, and practical considerations for implementation and use. The second report in the bottom left-hand side of your screen provides standard definitions for 6 equity stratifiers, namely age, sex, gender, income, education, and geographic location. The report includes those recommended constructs and measures for each stratifier, and these were developed in collaboration with Statistics Canada, and you can also find a summary of evidence supporting the association between the stratifier and health inequity. You can see in the circle on the right that race, ethnicity, and Indigenous identity are also, so those were also prioritized back in 2016 as key variables. But we realized that it was going to take us a little bit more time to really get at the underlying constructs and be able to develop a standard that could be used across a variety of different healthcare systems and settings. So why do we need race-based data? There is evidence of healthcare inequalities for racialized, ethnic, and Indigenous groups, both in Canada and around the world. But there's not a lot of this information readily available in the healthcare system to identify gaps and shortfalls in health service delivery. And to date, there are no pan-Canadian race-based data standards that were developed specifically for use in Canada's healthcare system. We know that the calls for race-based and Indigenous identity data grew louder during COVID. That relates to some of the earlier contextual information that I shared about why we're prioritizing sociodemographic data collection on this particular topic. We also know that pan-Canadian standards can help to ensure that high-quality racial Indigenous identity data is collected, analyzed, and reported using a harmonized approach. Researchers, provincial and territorial stakeholders, and advocacy groups have been looking to CIHI as a trusted source of data standards for use in the healthcare system specifically. So a little bit about the race-based data landscape. We know that the Ontario Anti-Racism Directorate Race Data Standard was released in 2018 and is currently being used in the education and justice sectors in Ontario. We've also seen the work of Dr. Andrew Pinto and his colleagues within the Upstream Lab. They've been conducting the SPARK study, which has been testing a modified Anti-Racism Directorate standard in primary care settings across Canada with great success. They've also been testing how we might collect other sociodemographic variables and data in the primary care setting, and doing some focus groups and participant observation, and really getting at some of the underlying issues that related to the collection of this type of data in primary care settings. We've also seen that BC recently introduced anti-racism legislation that was co-developed with Indigenous peoples in the province of BC with the goal of dismantling systemic racism and discrimination. And we have continuous calls from various researchers, provincial and territorial governments, and different stakeholders really looking to us for direction and guidance on this particular topic. And so what did we do? We actually released an interim standard for the collection of race-based data as part of COVID-19 response, COVID-19 data collection forms in May of 2020. This is because a lot of stakeholders knew that we had been working on this particular topic for a couple of years at that point, and they knew that they would be able to leverage some of the work that we had done to be able to integrate race-based and Indigenous identity data collection in their COVID-19 case report forms. We released that in May of 2020, but we followed up with a discussion document in July of 2020 because there needed to be a more fulsome discussion about how this data would be collected, could be collected, and get at some of the key contextual factors that would really help to mitigate the potential risk of harm that this type of data collection could cause. So we released a discussion document in July of 2020 with proposed race-based and Indigenous identity standards, and used that as really the foundation of ongoing conversations and consultations with pretty much anyone and anyone who wanted to talk to us about this topic to really understand it in a really sort of fulsome way. So that document was released in 2020, but we actually rebranded it as a supplementary report. It is available at the link on the bottom right of the screen as a supplementary report if you want to see some of that previous content. And some of the key findings that we illustrated and included in that supplementary report were really this idea that people were asking us and really wanted to see race and ethnicity as portrayed as distinct concepts. So race is a social construct used to categorize people based on perceived physical differences. So this is things like skin color or facial features. There's no scientifically accepted evidence of a biological basis for the identification and classification of discrete racial groups. So race is not about genetics. There's no scientifically accepted biological basis to race. However, disaggregating health indicators by race can help to identify, monitor, and address inequities that potentially stem from bias and racism. Ethnicity, on the other hand, is a multidimensional concept referring to cultural group membership, and it may be connected to other factors such as language, religion, or nationality. Ethnicity data can be useful for tailoring culturally appropriate health services, particularly at the local level. Indigenous identity is a separate and distinct concept, but it overlaps with both the concepts of race and ethnicity. But before we get into the standards themselves, I'd like to share some information about CIHI's Indigenous health strategy that Janine mentioned in her previous presentation. And CIHI has a dedicated Indigenous health strategy that really is based on 4 guiding principles. Those principles are that First Nations, Inuit, Métis peoples have inherent rights to self-determination, and this includes Indigenous data sovereignty, irrespective of where that data is held. Our work is guided by cultural safety and humility, and meaningful and respectful engagement are essential. The strategy also recognizes that distinct histories, interests, needs, and priorities of First Nations, Inuit, and Métis peoples, and recognizes the importance of acknowledging the differences between the various Indigenous groups in Canada. I think probably the most important thing is that any Indigenous related work or activities at CIHI are led through partnerships and processes with Indigenous partners. And it is those Indigenous partners that provide guidance and direction on how the work can, should, or does proceed. So when we think about Indigenous identity specifically as a potential social determinant of health that could be included in administrative health databases, we have to recognize that Indigenous groups are often considered alongside racial and ethnic categories in some of our existing data collection systems. But we also know that Indigenous identity data and measurement should be determined and supported by engagement with Indigenous communities. That's because First Nations, Inuit, and Métis have inherent and collective rights to self-determination, including ownership and governance of their data. So after we released the discussion document and sought out a process for engaging with partners across the country, we really engaged with partners and stakeholders to identify any potential support or concerns for the race-based and Indigenous identity standards with the goal of building toward consensus. We talked with a lot of stakeholders about the preferred approaches for collection, reporting, and analysis, and we gave special consideration to Indigenous populations and Indigenous identity data. Some of the partners that we connected with are listed in the box on the right, but it allowed us to really think about the messages that our key stakeholders were giving us when it comes to the collection of race-based and Indigenous identity data. And this here highlights some of the key themes from what we heard throughout all of those engagements. So for people who are being asked about their race or Indigenous identity data, there's an actual very real fear of self-identification for the potential to receive worse care. So there is a fear of self-identifying in particular settings that needs to be mitigated in order for patients or clients to feel comfortable disclosing this type of information. We also heard that there needs to be a clear purpose for why this data is collected, and that purpose needs to be stated up front, and it needs to be tied to actions. So it's not just about adding race-based or Indigenous identity data to different forms and then letting the data just sit there. It has to be tied to specific actions, and those actions need to be guided by the needs of the communities that the data represents. We also, so that actually highlights the issue of transparency. How is this data going to be used? How is it going to be used to improve the care for racialized groups? And we also heard that in order to mitigate some of the risk of harm, proper staff training needs to be provided. So if an individual person within the healthcare system is actually responsible for collecting this type of data from a patient or a client, then they need to be provided with the right training to ensure that they are collecting data and asking those questions in a way that is safe. We also heard that both community engagement and thinking through Indigenous data governance, but data governance in general, are key issues that need to be thought of early on in the process to ensure that the community voices are represented in the data that you collect, in the actions that this data is going to be used to inform, and that the data is protected in a way to really minimize that risk of harm. The other theme that comes up a lot in conversations about the collection of race-based and Indigenous identity data is the concept of intersectionality. And it's often not just about, a person's race or experience of racism, but it actually relates to other social determinants of health, things like income, education, housing. So thinking through how that concept of intersectionality is going to be reflected in the data you collect, but more importantly in the analysis and reporting that you do, is another key theme that came up through those conversations. And so based on all of the information that we gathered and the conversations that we had related to the race-based and Indigenous identity standards, in March of 2022, CIHI released guidance and standards on racialized group and Indigenous identity for voluntary adoption by health systems. The standards itself includes 2 data collection items. This is a distinctions-based Indigenous identity question followed by a race-based data element. But really, through all those conversations that we had, it's less about the actual data standards themselves and more about that contextual, the contextual factors that are going to mitigate the risk of harm for if and when this data is collected. So we organized it as sort of 3 key themes around community engagement, data governance, and some of those key processes for safe collection. And those are essential for implementing any race-based and Indigenous identity data collection. So this on your screen shows you that Indigenous identity data standard. It is consistent with administrative data standards that we see elsewhere, such as in the census, the BC Administrative Data Standard, and it really just asks you to identify as First Nations, Inuit, and or Métis, and the response categories are select all that apply. There's a note that is repeated on this particular standard saying that the implementation of Indigenous identity data standards should include data governance agreements, engagement with appropriate Indigenous authorities, and processes related to culturally safe data collection. This is a minimum standard. There's actually optional additional details that are also possible to include. And those would include additional details about, for example, for the First Nations, whether they're living on versus off reserve, status versus non-status, participation in a land claim agreement for the Inuit, and so on. So those are optional additional details, which really would be determined based on the engagement done with Indigenous peoples for the collection of this type of data. So they would be able to guide you in how those additional details should or should not be included. And so this slide shows how the data standard compares to Statistics Canada's population group and Indigenous data standard categories. So you can see the CIHI standard on the left, StatCan's census of 2021, and then an example from a recent Canadian Community Health Survey. So this is pretty consistent across a variety of pan-Canadian data collection efforts, which is important when we think about the interoperability and how we might be linking some of this data. It's important for us to use consistent standards in different settings so that we can have meaningful analysis using linked data sets, for example. Oh, and here is where shows you some of those optional additional details that could be included alongside the minimum Indigenous identity standard. This next slide shows you CIHI's race-based data standard. So on the left, you can see the question, in our society, people are often described by their race or racial background. These are not based in science, but our race may influence the way we are treated by individuals and institutions, and this may affect our health. Which category or categories best describes you? Check all that apply. And then there are some response categories that are given with examples of those groups. So the question itself is supposed to highlight the issue of racism. And so that's why we included the piece around how people are treated by individuals and institutions. And you can see that there are a variety of different response categories. When possible, you should include another race category, and ideally you would provide people with open text. That would be particularly important because although these are sort of the best large categories for grouping racial groups, some people still will not see themselves in the response options that are provided. And so by providing another race category, it really allows people to identify in the way that they decide, which is the ideal way for this type of data to be collected. And I will highlight that that guidance document, it does include the standards, but it also includes the key issues and some it provides direction to some key resources related to, in this example, community engagement. So community engagement is the best practice and foundational to the respectful collection and appropriate use of race-based and Indigenous identity data in healthcare. The image on the left just shows you a potential resource that is highlighted in that guidance document. Community engagement should be a prerequisite for establishing data governance agreements with Indigenous peoples and governments. And the community members can provide valuable input about how this data can be collected, how this data can be used to improve the care experience of racialized groups, because they have that lived experience and local knowledge that will be valuable in tailoring the data collection and analysis and reporting. Similarly, Janine highlighted a lot of CIHI's work on data governance in the previous presentation, but data governance is a key issue that needs to be well thought out in the context of race-based and Indigenous identity data. We know that strong data and information governance ensures that data is timely, trusted, and accurate. And these should be reviewed and revised as needed with special focus and consideration given to the impact on Indigenous peoples and racialized groups and on how their data is collected. I will tell you a little bit about the governance of Indigenous data here at CIHI specifically. And in August of 2020, CIHI implemented a policy on Indigenous identifiable data that reflects the principles of Indigenous data sovereignty, including OCAP. Based on what we heard, it was to help ensure that the data that we have here at CIHI, whether it be from hospital setting, home care settings, long-term care, that we want to ensure that that data is used in appropriate and safe ways. So as a result of this release in 2020, we have looked at other policies and procedures within our organization to make sure that they have been updated to align. And when needed, staff training and support are provided. The policy at a glance: Indigenous identifiable data is only released with approval from appropriate Indigenous authorities. That's the policy, that's how it's applied, and that's what Indigenous data governance looks like at CIHI. In our guidance document, we also highlight the importance of safe data collection. And so this is really about, how can we ensure if race-based and Indigenous identity data collection is being implemented in a particular healthcare setting, what might be some of the staff training or information needs of the people who are responsible for collecting the data. So providing staff with that training and clear instructions is essential. Things like a staff script, and resources on topics such as implicit bias, are included, and there's a variety of different safe data collection resources that are available in the guidance document that we released. Like I said, through all the conversations that we've had with regards to the collection of race-based and Indigenous identity data, making sure that these contextual factors are dealt with is key to mitigating or minimizing the risk of harm that this potential type of data collection, that there's risks associated with it. So if you're at the point where you have the data and then you have race-based Indigenous identity data, and you've sort of followed those guiding principles for how that data is collected, if you're looking for particular resources on what to do now, we do have a Measuring Health Inequalities Toolkit, which provides a variety of different tools across sort of 3 phases for measuring health inequalities: the planning of your analysis, analyzing your data, and reporting your findings. There's a link at the bottom of this page. It's really tailored to analysts and researchers with varying knowledge and skill sets. And there are updates coming on June 9th. So if you are interested in some of the actual how you take the sociodemographic data and turn it into the health inequalities measurement for a particular analytical report or for regular health system performance reporting, there's a variety of different tools available here that could be used to guide you in the work. We know that to advance equity in healthcare, our health systems need to be able to recognize and respond to the health inequalities experienced by racialized groups. Race-based and Indigenous identity data standards are just one tool that we can use for anti-racism and reconciliation efforts going forward. And that's it for me. I'm going to figure out how to stop sharing and look to chat for the
That's okay. We can probably just leave it